Yes, yes.
Hello and welcome to Health Live at Seniors today. We are here on the last Saturday of the month of January 2024. And we have here with us a senior doctor from Mumbai who's going to be talking about a very important topic, which is recognizing and reacting to senior citizen emergencies. I will introduce and welcome Dr. Roohi Pirzada here. Dr. Roohi Pirzada is a senior physician practicing in Mumbai, as I mentioned. She was with the Bombay Hospital for a fair number of years, and she has around 2 years experience as an intensivist. She also consults with Apollo 24/7 and Data 1mg, and she has been a specialist in critical care medicine. Welcome to Health Live at Seniors today, Dr. Pirzada. How have you been?
I'm fine, thank you. First of all, Mr. Maheshwari, I would like to thank you for this warm welcome. And it's a pleasure being on this amazing platform today.
Thank you very much, Dr. Pirzada. I think the topic that you have is very important. We've been discussing a fair number of topics over the last 3.5 years that we've been conducting these sessions. And while we have on specialized areas like cardiology, we have people for diabetes, we have ENT, we have dental care, respiratory ailments, and the like. But in the recent past, we keep, looking at information that we get, requests that we get from our attendees, from our regular attendees, and they've been raising some of these issues. So, for instance, we had last week we had the session on vitamin D deficiency. Now we've done vitamin D deficiency. We've discussed it in passing several times over, but these are topics that are there, and which is why we thought it would be good to have you here and discuss this entire issue about emergencies for senior citizens, and and how does one react to an emergency? More important, how does one recognize and react to an emergency, and what does one do? Who does one go to? And in cities like Mumbai or Bangalore, where we have a lot of people who are there, by reacting to it, first of all, there's so much traffic. How do you manage? How do you manage to go to an emergency? We also have a situation where, once again, I can tell you from my own personal experience, the general physician, the category of general physicians is almost vanishing, because today in a city like Mumbai, if I am a general physician, I'd rather give my space to a bank ATM and make there. But the general physician has virtually vanished, and how does one go to a general physician? I can tell you, I have not had a general physician, a family doctors as they call, for the last 20 years.
The concept is gone.
That thing has gone, and that's a worry that is there. So I would, we will of course invite questions from our attendees today. So for all of you here, as always, let's wait to hear what Dr. Roohi Pirzada is going to be saying here. And after that, if you have any questions, please put them in the Q&A tab. As always, mention your age and gender. You can also mention your location, because some of the questions may be around the location. You can also mention that. And we will take the questions at the end of the, after her talk is over. We're not going to be having a presentation today. She's going to be making a talk. So let's hear it from her, and then we will look at the questions after that. Over to you, Doctor.
Thank you, Mr. Mishra. So, good evening, everybody. So, welcome to today's session on geriatric emergencies. And as an intensivist, I have this first-hand experience of these unique challenges, which arise in emergencies, especially involving the seniors. But as I said that, I also have witnessed the amazing resilience of older adults. And I believe that with the right knowledge, we all can be better equipped, to handle these emergencies. So we'll delve into topics like medical management and advanced directives. This way we'll be able to, kind of empower our loved ones to navigate emergencies with a lot of confidence and grace. So let me walk you through some geriatric emergencies, which, if identified in time, can really help minimize mortality. And especially, you would say, in preventable deaths like cardiac events or cerebrovascular events, electrolyte disbalances, and metabolic conditions like hypoglycemia, respiratory emergencies, pulmonary thromboembolisms, and maybe aspiration pneumonias as well. So let us get to the first one, the most commonly heard of, heart attacks. These days, the incidences have in fact increased. So what exactly is a heart attack? I would want to explain these things in a language and in a manner where everybody is able to relate and understand. So I will try as much as possible to avoid extremely scientific, vocabulary. So let us see what is a heart attack first. Now, this is obviously a cardiac emergency when the coronary artery, that is the artery which gives blood supply to the cardiac tissues, is blocked suddenly, by a thrombus. Now, what is a thrombus? It's a clot. So, this artery which gives blood supply is blocked by a thrombus or an atherosclerotic plaque, which is a cholesterol plaque or a deposit. Now, this cholesterol plaque,
sorry to interrupt. Your voice is echoing. Is a speaker on? Do you have a speaker on it and around you?
No, none of them.
Okay.
Better now? I mean,
can I just make a request to you? All of you over here, you can also be privy to this advice. I couldn't hear on your laptop, just at the lower end of the left hand, there's a mute button. Next to the mute button, there's an arrow. If you can go to the arrow and just go to audio settings. Can you go to audio settings?
Yes.
Now, in audio settings, there's a lower down, there's a thing called echo cancellation.
Let's see something like that.
Audio profile, under audio profile.
Yeah.
There's something called
background noise removal is there, auto, low, medium, and high. And live performance audio. Yeah. There's nothing like an echo. Mute my microphone while joining. Yeah, that's about it. Is it fine?
Above that.
Yeah.
Above that, there's something called under audio profile, and above all these things that you've mentioned, there's something called high fidelity music mode, echo cancellation, and stereo audio.
Okay, but this is not showing in mine here. This is all which is showing. Adjust microphone volume. No, none of that which is said.
Above that, there's a thing.
Audio beta recommended for multiple instruments. So this is for musicians, I guess.
Firoz, can you advise?
Ma'am, there is under audio profile, there is called as original sound for musicians. Can you please click on that?
Yes, original sound for musicians. Echo cancellation. Okay.
Yeah, please.
It was already marked. Echo cancellation was already selected.
Ma'am, Unmark please.
Unmark it. Okay.
And the first option will be high fidelity. Just check that, and the rest two options below that, the number 2 and number 3, you need to cancel it.
Fine. Done.
Yeah, ma'am, you can cancel it from above. It's done.
Sure. Okay. So this is better, right? I mean, there's no echo now.
It is slightly better. What you can also do is, while you are speaking, because I'm sorry, these things happen, and all of you
absolutely
dealing with technology. Until your presentation is over, just keep talking and reduce the volume of your speaker if you can. Do you think that will help, Firoz?
Okay. Yes.
Yeah, sir, actually.
Reduce this to 35.
Ma'am, can you take it to 20, please? The laptop volume, can you take it to 20?
Okay. This is okay? Yeah, to 20 now.
Yeah, this is hopefully better. To all of you here, to Mr. Rajiv Kumar, Mr. Shah Mittal, who said that, the voice is echoing. I appreciate, but, these technology issues happen. And so could you start again from the point that you were raising, and then we can, we'll of course ensure that the edited video doesn't have all these things. But we will ensure that these things are edited out from the final thing that comes.
So where
over to you
you
again. Sorry.
Now?
From where you were talking, perhaps just 2 minutes
let us
before
go
that,
to
you
heart
can
attack.
start.
Yeah. Fine. So I was talking like, what is a heart attack basically? Now, this is a cardiac emergency, of course, where the coronary artery, which gives blood supply to the cardiac tissues, is blocked. Either it is blocked by a thrombus, which is a clot, or an atherosclerotic plaque, which is a cholesterol deposit, which builds over a certain period of time. It is not very sudden. So what happens is when this coronary artery, which is supplying the blood to the heart muscles, is blocked suddenly, what will happen? Obviously, the territory which it is supplying, the myocardial tissue which it is supplying, will die without a supply. It is just like, cut off the supply and the tissue dies. So this is nothing. It's very simplified way of speaking, and this is what we call as heart attacks in normal terms, or myocardial infarctions, as we call it in medical terms. So this particular dead tissue becomes non-functional. And then the symptoms start, appearing. And sometimes even before the infarct also, you start getting these warning signals. Now, what are the signs and symptoms of an attack or a heart attack? How do you identify it? Most importantly, because maximum cases get missed because people do not identify it in time. So, they are devoid of treatment. So, how do we go about it? First of all, very classical sign, I know everybody of us here know this, it's a persistent chest pain. But what kind of pain? It has to be a squeezing or a crushing or maybe a different kind of a heaviness in the chest, extreme heaviness in the chest. This sometimes may radiate to the neck or the jaw, sometimes to the back, and I have even seen cases with an upper abdominal pain. So that is the reason a lot of people come and say, okay, doctor, I'm having this gastritis symptoms, I'm having this acidity, vomiting, nausea. So I don't think it is cardiac because this mimics a gastritis. So there, a lot of people, take a Nino or a Pantop at home, and they think that this will settle. A big mistake. What will happen if you go to a ICU or a casualty? At the most, you just have to take an ECG, but you're safe. So when you feel it is an unusual pain at an unusual time, in spite of not having taken any heavy meal, you should never neglect this. Acute shortness of breath. When you don't have an asthma, why would you have a shortness of breath? Cold sweats. Sometimes even people, pass out. They have a syncope, that is fainting. So, as opposed to an anginal pain, these symptoms do not ease with rest. Once again, I repeat, these symptoms will not ease with rest. People, who have luck by this side will have these warning signs and symptoms maybe a few days or at times even few weeks earlier to this decompensation. So they really are lucky to know what is happening. But a lot of people, as I said, will ignore it in spite of getting these signals. So anginal pain will relieve at rest, but this pain will not relieve at rest. Okay, so this is a very classical signal we should not ignore, and in time you should just go and get your ECG or a 2D echo done to be a double sure. So how does this happen? How is a heart attack caused? Of course, we know it's a partial or a complete blockage of the vessels, that is, which supplies to the heart tissue, as I just mentioned. But this happens mainly because of certain risk factors, which I'll be discussing shortly. And second, apart from this blockage, there are other reasons also for a disruption in the supply of blood to the heart vessels, just not a blockage. There are other reasons as well, like a coronary artery spasm. It is not a blockage, but it is a narrowing of the blood vessel. Sometimes a very severe narrowing of blood vessels also can give the same effect. The blood supply will be cut off. And then there is a coronary artery dissection, which we call as SCAD, spontaneous coronary artery dissection. Now, what is the dissection? It's, in short, I would say it's a rupture of an artery. Again, what happens is the blood supply is hampered. Then certain viral infections, like COVID-19 and hepatitis B, C, and sometimes even parvovirus I've seen, leads to viral myocarditis. It's a viral infection of the heart, you would say. And this viral myocarditis can trigger a heart attack or a cardiac event. So these are basically what causes a heart attack, not just blockage, but spasms or even viral infections can cause heart attacks. Okay, so which I just mentioned that I'll be telling you certain risk factors, or people who are at a high risk are men above 45 and women above 55. Then this is tobacco and smoking habits, extremely high risk. Nowadays we are seeing a lot of people at younger age, with smoking habits coming in the casualty with MIs, that is myocardial infarctions. Then there is this long-standing backdrop, of hypertension, maybe 10 years, 15 years, 20 years. Depends. It's a subjective thing, We never can say that, okay, after 10 years, this is going to happen. No. So this long-standing hypertension may damage the coronary vessels, their linings, especially internal linings. Then, of course, our favorite dyslipidemia, that is high triglycerides or LDL levels, which result in plaque formation, or as I said, the blockage, the clot formation. Then obesity, of course, metabolic syndromes like diabetes. Then unhealthy diet and sedentary lifestyle, especially for people who have worked from home. This has become like very commonly seen in the younger age groups, obesity and unhealthy. Rheumatoid, but of course not so directly linked. But yes, they do have certain role to play. Then there are certain, prothrombotic states. Prothrombotic means those conditions which may trigger a thrombus formation, may trigger a clot formation, like malignancies or pregnancy, then chemotherapy. These are certain groups which are at a high risk factor. As I just wanted to confirm with you people that you should know that you fall in particular category or no, and you'll be more cautious about those things. Now, in case, suppose this happens at home, somebody has a heart attack or an MI at home, what do we do? What should the drug box contain? The emergency drug box should always be there in every house. What should it contain? First of all is vasodilators. Now, what are vasodilators? As the name suggests, vaso means a blood vessel. It has to be dilated because somewhere we have to restore the blood supply back to the tissues which are getting compromised. So how do we do that? Immediately, somebody has to be rushed to the hospital for angioplasty. But meanwhile, what do we do? How do we, prevent the cardiac tissue from further damage or severe damage? Vasodilators help. Sorbitrate. I'm sure everybody of us here must have heard of sorbitrate, which is, kept under the tongue sublingually. So it immediately dilates the coronary vessels. The chest pain is kind of, relieved to an extent. Plus, the main motive of giving this vasodilators is to partially restore the blood supply to that tissue. Then aspirin, dispirin, because they are antiplatelets, they avoid or prevent the thrombus formation. And of course, severe cardiac ischemia will be avoided if it is taken. But again, it has to be taken only if there is no contraindications. Means somebody who's had a very recent hemorrhagic stroke or a very recent major surgery, or like a bleeding tendency, should be very cautious. Do not take this unless you consult or your family member consult somebody on the phone as a first aid. And of course, not more than 300 milligrams. Then the third drug which should be there is statins, cholesterol or lipid lowering drugs like atorvastatins or rosuvastatin, Storvas hai, Atorva hai, Rosuva hai. Aajkal we have all these brands which, all of us know of these brands. So this should be there ideally in an emergency drug box. A statin, a vasodilator, and aspirin. At least, something you have done at home to relieve the pain and further, probably, you might save yourself from a mortality in this case. Probably. It is not like definite, but yes, at least we are trying from our end. And of course, as soon as possible, reach the casualty door. That is the mainstay of being aware of what is happening. So this was in a nutshell about cardiac emergency, that is a heart attack. Now, the second common emergency in elderly is the metabolic emergency, that is the hypoglycemia. What is hypoglycemia? This happens mostly in diabetes, I would say that. So when the blood sugar levels drop below 17 milligram per deciliter, it's called as hypoglycemia. Okay, it's not severe, but it is hypoglycemia. And when it is below 55, then it is a severe hypoglycemia, which can be fatal also. Now, let's touch base with its common causes. Excessive or inappropriate insulin dosages in reference to your carbohydrate consumption. I won't say that if your doctor has given you 16 units, that is wrong. No. But if you happen to take 75% of your carbohydrate intake on that particular day or meal, then taking 16 units will be excess. That time, what happens is many of the diabetologists nowadays have started giving a sliding scale, to modify or titrate insulin dosages in case you feel that, okay, today I have taken, say, one chapati instead of two. You can titrate it as per your, check your sugar. If it falls in this range, -2. If it falls in this range, -4 units. And that is how you can take a sliding scale to titrate your doses. Then second is, if your timing is not consistent on a day-to-day basis of taking the insulin shot at the same time as necessary. Okay, 5 minutes here, there, 10 minutes is fine. But it shouldn't be like, 45 minutes or 30 minutes apart, So you keep your timings and your food timings as well as your insulin shot timings consistent. Third is, if there is any alteration or change in the physical activity levels. That also, obviously, because consumption and usage of calories will be different in that time. High altitudes and alcohol consumption, rarely. But I'm just mentioning it because they do have, small role to play here. How do you identify the symptoms of hypoglycemia? Jab kisi ka blood sugar goes low, what do you come to know? First is, you feel giddy, blackout, sweating, you'll feel uneasy. There will be a high heart rate, tachycardia, that is more than 100 per minute. So that will be one more symptom of hypoglycemia. Confused state or maybe a disoriented talk. You're confused, where are you, what is happening, you're talking irrelevant, you are anxious. And sometimes, in severe hypoglycemia, as I said, below 55, the patient may even have a seizure. He'll throw up a seizure and slip into a diabetic coma. I've seen patients with 25 or 30 coming in a diabetic coma. So managing hypoglycemia at home is super essential. Before any medical help arrives, you need to get your sugar levels up. So I'll introduce to you this 15-15 rule. But this is only good for a moderate hypoglycemia, not for the severe ones. Between 55-70, we can do this 15-15 rule and take it ahead. Now, what is this 15-15 rule? Taking 15 grams of carbohydrates and recheck your blood sugar level after 15 minutes. So if it is still low and it is not in the desirable limits, repeat the same. Again, take 15 grams of carbs and again recheck your blood sugar levels after 15 minutes till the desired levels are achieved. So how do you know what is a 15 grams carbohydrate? Simple. Sabke ghar mein hai 1 tablespoon of sugar or 1 tablespoon of honey or a tablespoon of sugar syrup. That's also okay. Very easy and handy. But if you have a cup of, half a cup of fruit juice or, your Tetra packs which are like loaded with sugar, or a regular soda drink also should be fine. Then say 3 to 4 glucose tablets, which nowadays has become a fashion to have your glucose tablets in your cars or in your bags. But yes, it helps in such emergencies. So you can take 3 or 4 glucose tablets. That's also good enough. Or jelly candies, hard sugar boiled candies, very good. 3 to 4 of them should be good. Now, but always remember that you should never have a high fat or a high fiber diet with carbs, because what happens is with high fiber or high fat, it slows down the absorption of carbohydrates. That is why your blood sugar level doesn't build up that much. It is always on the lower side. So avoid doing that, so that you're not having any such episodes of hypoglycemia. Now, 15-15 rule, see, doesn't give instant results. That's the reason I told you that we need 15 minutes at least for some change to see. Otherwise, just take a Glucon-D, mix it up and have that glass if you're for it. what do you do in severe hypoglycemia? This was okay for a moderate one. But if somebody is unconscious or it is a severe hypoglycemia, cold extremities, sweating, unconscious or partially conscious, you know that this person's sugar has dropped. Even, family members are well read enough to know and identify that condition. So in that, a glucagon kit is available on prescription. Injection glucagon is the mainstay treatment in that. There's no other choice. And the family members or caregivers, they should receive the training for how to use it, when to use it. All that training should be given to the caregivers. And if a person is unconscious, say within 15 minutes or so, they should, regain their consciousness. But please seek medical help in the interim period. This is just a first aid because hypoglycemia will not be corrected so instantly. It is bound to come back in some time. Okay, so this is just like we are buying time. Take the patient to the casualty, monitor the blood sugar, IV glucose, and whatever it may take ahead of that. But it should not just stop here. Okay, now my sugar has come back. No, it is going to fall back. Okay, so just be a little more vigilant about that. And for the next 2 or 3 days, definitely, you'll have to monitor your blood sugar level very tightly, like 3 or 4 times in a day, sometimes 5 times in a day. So, and then of course, you discuss with your diabetologist about the changes you need to make in your diet or in your dosages of insulin. So this is, manageable at home for buying time, but not in severe hypoglycemia. Okay, if it is 70, 69, and then it comes back to 140, 150, monitor it again. You don't need to rush in that case. But if it was 35, 40, you give glucagon, but you have to take the patient just to avoid any diabetic coma or damage to the systems. So again, easily manageable, but fatal, it can be fatal. Thirdly, we come to electrolyte imbalances. Now, electrolytes are of a variety, sodium, potassium, calcium, phosphorus, magnesium. But in elderly, we see these two majorly, that is low sodium levels and high potassium levels. Now, low sodium levels, which we call as hyponatremia. Hypo is low, hyper is high. So, hyponatremia. Now, why does this hyponatremia come in? Because what happens sometimes we have low salt intake because, okay, people are having blood pressure. So they tend to have a low salt intake. Plus, on top of that, if they have a cardiac or a renal issue, kidney issue, they have a combination of antihypertensives, like Telma H. Now, what is that H? H is nothing but a diuretic. It makes you pass urine. So what happens is there is a loss of electrolytes to the urine. So one of the very leading causes is diuretics, especially thiazides. Then we have these drugs like antidepressants and anti-epileptics. Then somebody who has a compromised liver function or a kidney function may have a low sodium as well. Then hypoactivity, low activity of adrenal glands or thyroid glands. These are endocrine glands, but not a very big contributing factor, I would say. But I've seen certain malignancies, like especially pulmonary lung cancers have been showing this hyponatremia. A lot of patients who are good and not in a very bad, bedridden state, they still I've seen people with them having low sodium. And urinary tract infections, of course, because you're excessively passing urine. So, but yes, it is not a very major contributor. Majorly, as I said, is low intake of salt and diuretics, that is thiazides and drug. It's mostly drug related. Then how do you know that this is hyponatremia and not hypoglycemia? Of course, you will have your glucometer, you will check your sugars are fine. Then what is the reason of this disorientation or altered sensorium, nausea, vomiting, confusion, confused state? You're not identifying people, you're not understanding which day it is. You suddenly start talking irrelevant things. And your sugar is normal, you don't have a stroke. What is it? It is severe hyponatremia. So, and sometimes it may even, manifest as seizures or coma and even cardiac arrest. So, of course, not in a mild one because 135 to 145 is the range. So, if it would happen at 130, that is like a very severe hyponatremia. It will require admission and hypertonic saline IV. Hypertonic saline is a concentrated saline which is given IV and monitored. It is not as easy as just give it and leave. No, it has to be monitored. It has to be given in a certain pace at a certain speed in order to avoid any complications. And in case a person shows this regular hyponatremia, like you say to your doctor, mera sodium is always 128, 130. what do we do? So he may consider adding certain drugs like tolvaptan or colivaptan. I'm getting a lot of patients' prescriptions with these tolvaptan and colivaptan on board because, yeah, repeated hyponatremias are happening because of thiazides. And the reason being we cannot stop the thiazides as well. So we have to find an interim, solution for that. So yes, tolvaptan and colivaptans are having good results. They are getting up the sodium levels well enough. Then the second electrolyte which I would discuss is hyperkalemia. It's hyper now, it's the opposite. Kalemia is for potassium. So what is it? Potassium levels are generally 4.5 to 5.5. But if this exceeds 5.5, it is a serious and a life-threatening medical emergency. Okay, but not 5.5 or 5.6 ho gaya. No, I'm not saying about that. But when it increases, it has a certain reason to increase, and it will not increase just to 5.6. It will increase considerably. So how is this precipitated? Mainly when a person is having an impaired kidney function, CKD, very, very, very common causes chronic kidney disease. And what happens is the kidney is not able to throw out the potassium, as much as a normal kidney would. Then there are certain drugs like ACE inhibitors or use of salts with potassium chloride. Like, these low sodium salts are having potassium chloride in that. So if you're using any low sodium salt, please make sure about the potassium levels in that, potassium chloride especially. Then what happens when this particular hyperkalemia is happening? There may be diarrhea, nausea, muscle weakness or tremors, muscle cramping, and slow and thready or very irregular pulse rate. You will start feeling palpitations also at times. Arrhythmias, that is irregular heart beating. The pattern, the rhythm of the heart is disturbed and it may throw up an arrhythmia. Sometimes patient may collapse. A lot of them come in a collapse state in the ICU. Since I have worked as an intensivist, I have seen people coming with a collapsed, state. And immediately when we plug in the ECG shows like tall T waves alongside, of course, a high serum potassium on a blood sample. That confirms it. The tall T waves, we come to know this is a high potassium, and the blood sample also confirms that. Okay, doctor, the levels are 6.2 or 7.4, 6.9. I'm talking about that levels. So treatment has to begin immediately, definitely immediately. And mainstay remains like with IV calcium gluconate, IV soda bicarb. These are anti-hyperkalemic measures have to begin. And a very important treatment modality here is a GI drip. Now, what is a GI drip? It's a glucose insulin drip. Very confusing, right? Glucose insulin drip. Now, what happens is you use insulin to push the potassium from the blood levels to the cells inside. At least you have to reduce it from your blood levels. How do you do that? Insulin pushes it back into the cells, and your blood levels start coming to normalcy. But if a person is not a diabetic, I give him like 10 units of insulin. What is going to happen? He'll go into hypoglycemia. So to counter that hypoglycemia, we are giving this insulin along with a glucose solution, a dextrose solution. Understand? So insulin is given to bring down the potassium, but to bring, to counter the hypoglycemia, we are using the insulin in a dextrose solution, 25% dextrose or 50% dextrose, and insulin together, so that we are achieving the low potassium levels also, plus we are not causing hypoglycemia. So, but people who have this kidney issue background, I mean, it is not just because of some drug or anything, but they have a background kidney issue, CKD. They may need an urgent dialysis as a life-saving measure, a couple of dialysis maybe also. So it depends on the levels, because if somebody is having like an 8.9 level, it is not just going to come down with these IV measures. So in that case, we may need to take the patient to a dialysis AKU for a life-saving dialysis urgently. And yes, it's very easily correctable. It is not going to be put you on potassium lowering sachets if you have a CKD. So this is again life-threatening, but a not very known, electrolyte disbalance. But people who have this kidney issue, I'm sure you might be aware of. Why do you tell them not to eat this, not to eat this? Because we don't want the potassium to be high, because it's a fatal condition. So this was about the electrolytes. Now I'll move on to the fourth one. It is the cerebrovascular accidents, or in short, strokes, as we call it, as brain attacks, because the etiology, the pathophysiology is similar to a heart attack. Same thing, acute compromise of the cerebrovascular perfusion. Here it was the heart muscles, but in this case it is the cerebral tissues. So cerebrovascular perfusion when compromised leads to a stroke. And there are two types of stroke basically, but 85% to 90% of them are because of a compromise of the perfusion, compromise of blood flow. They are called as ischemic strokes. Ischemia is a lack of oxygen and blood supply. And the rest 10 to 15% are hemorrhagic strokes, brain hemorrhages, intracranial bleeds as we call it. But they are the lesser, percentage. So we will limit this discussion to the ischemic strokes because it's a definite emergency. And if you get the patient in that 1 hour golden period, it has beautiful outcome results. But the later, the lesser prognosis and the outcome will not be as favorable. Maybe, there'll be some residual, remains of that. Like it will not be a complete reversal. So prompt identification of symptoms and rushing to the hospital can influence this prognosis substantially and curtail mortality rate. So that golden hour shouldn't be missed, please. Now, how do you know what is a stroke? It's not side limb, it can be 4 limbs, it can be the side of the body, it can be just the face. So heaviness in the limbs, inability to lift your limbs, facial palsy, ataxic gait. Ataxic gait is like an imbalanced gait, you're falling off balance. So ataxia is again a sign of cerebellar infarcts basically. So the small brain infarct. Then there is dysphagia, difficulty in swallowing or difficulty in articulation or absence of speech, totally absent speech, person has become mute. So these are very common symptoms and management is also very, you cannot manage this obviously at home. So early intervention is brought in a 60-minute window frame. It is golden timing. And then you can, get back almost 100% reversal if can be tried. Then early intervention with RTPA. RTPA can minimize tissue damage and it supports a positive outcome. Then there is mechanical thrombectomy. When you put in a catheter and extract the thrombus, the clot. It's gained popularity in this recent, years. And of course, gold standard treatment that is antiplatelet agents, like Dispirin, aspirin, heparin. Heparin when in hospital, and then maintenance will be with the Dispirin or aspirin. So this is in short about the stroke and its basic management strategies. The last one which I want to cover is the respiratory emergencies now. Now, respiratory emergencies, I'm going to take up two things. One is the pulmonary embolism and one is aspiration pneumonias. Aspiration pneumonias are very common because what happens is in bedridden elderlies who are being fed in a lying down or a semi-propped up position, food or liquid can very easily pass into the trachea, that is the windpipe, instead of the food pipe, that is the esophagus. Very common. Why? Because if this thing happens to us, what will we do? We will start coughing vigorously. And why? Because our cough reflex is triggered. And then we throw out that particular particle. Right? But elderlies who already have a low cough reflex cannot do that. And this passes directly into the lungs. The lungs get inflamed. There is an infection which leads to pneumonia. A very bad pneumonia. Aspiration pneumonias are nasty. And a lot of them may even need intubation and mechanical ventilation, invasive ventilation. And long-term antibiotics till the patches on the chest X-rays are resolving and the oxygen levels start coming up. Because if not treated in time, it can So when does this happen? Will a complex be weak? It won't be in a normal person, because as I said, we'll be able to cough it out. It's seen in post-seizures. When you had a seizure and it's a post-ictal phase, a person is not completely conscious. He's still in the post-ictal confused state, not in a complete aware or in a, awake state. Then strokes, again, because some strokes will affect the muscles of the limbs as well as muscles of digestion, muscles of, breathing. And a lot of stroke patients will have this risk factor. Parkinson's again. Then patients who have an altered sensorium, even for a temporary cause like an electrolyte imbalance, like we just discussed low sodium, where the patient is altered sensorium. Because suppose the patient has had a meal, he's not a bedridden patient, he's had a meal sometime back, and then the sodium was on the lower side and he becomes a little altered. What will happen then? Obviously aspiration, because he may try to gag or puke out. and then he may aspirate it because it will not have come out. It would have gone into the windpipe instead of coming out. So altered sensorium and a low or a poor cough reflex. These are the two reasons. It will not happen in somebody who's not had these issues. Okay, we try lying down and eating kuch gaya, to we start, as I said, throwing it out. So again, you have to be very cautious if you're handling, an elderly at home who's been fed. So what do we do in these cases? Because when we know that this patient's sensorium is not completely well, we feed them with RT, rice tube feeding. And safe because RT straight away goes into the stomach. So all these ways are bypassed from here. So there is no risk of aspiration. Aspiration is a very dangerous thing. A lot of people are not aware of it. But once aspiration happens, sometimes it's very difficult to bring the patient back in the ICU. If it is excessively late or if septicemia sets in. Then the second respiratory emergency which I was talking about is the pulmonary embolism. I am not very sure if a lot of us would have heard this here. It is a blood clot which gets lodged in the lung arteries, in the pulmonary arteries, and blocks the blood flow to the lung. Now, where does this blood clot come from? Lung mein kahan se aa gaya, right? So this clot usually forms in another part of the body, especially the calves, the deep veins in the leg. You have heard of this term, deep vein thrombosis, DVT. So wahan pe it gets formed. This clot ka primary site is over there, and then it detaches and it embolizes to the pulmonary artery. It travels in the bloodstream and reaches the pulmonary artery. That is why पहले वो thrombus होता है, उसके बाद में when it detaches, it is called as embolus. So embolus. So that is why we name it as pulmonary thromboembolism. Thrombus से it becomes an embolus and it goes into the pulmonary artery and sticks over there. And how do we come to know this? The presenting symptoms are acute shortness of breath, like chest pain होगा या cough होगा किसी को. And acute shortness of breath क्यों होना चाहिए? When you don't have a COPD, asthma, there is no trigger. Why does this happen? Chest pain, a different sharp chest pain, coughing, sometimes even hemoptysis, and low blood pressure. So again, this needs an urgent admission. There's nothing which you can do at home, but you should know that this is a possibility and I should not take this lightly. Because you need to be immediately admitted for hypoxic care. The oxygen will definitely drop because your lungs are not, you're short of breath. So hypoxia will be taken care of as well as hemodynamic stability should be achieved. Like as I said, the BP would be dropping. So you will need to achieve that hemodynamic instability. So you'll have to take care of that. Then what do you do in that case? After you achieve this basic primary care, the clot will be thrombolized just like your attacks, heart attack or the stroke. And catheter-directed mechanical embolectomy. Again, you put in a catheter, extract the embolus. And of course, maintenance will be with heparin therapy, that is a blood thinner. Very standard protocols these are. And repeated episodes may happen in certain class of people. In that case, there is something called as an IVC filter, the inferior vena cava filter. That may be installed, implanted. So that it's like a filter, as the name suggests. If the clot even gets dislodged from the leg, it won't be able to reach the pulmonary artery. It's trapped in that filter. And that happens, that call is taken as per the condition of the patient and the requirement and how much he is at risk for the embolism repeatedly. So now who are these people who can be at a risk? See, when a person is bedridden or in post surgeries, post hip surgeries, major abdominal surgeries, arthroscopies हो गया है किसी का, या फिर यही stroke से people are bedridden and they don't have movement of the calf muscles, there is no circulation. So in that, the blood is static. It starts forming a clot. It is not moving. It is not in motion. So that time the blood becomes static and starts forming the clot. That is why stroke pe why people call the physiotherapist in the ICU or at home for passive exercises. The patient is not able to move, so he has to be moved by somebody else, right? So that these complications do not arise. And as I said, all those conditions, spine surgeries में हो सकता है. Then Parkinson's hai, pregnancies mein, malignancies mein. These are all prothrombotic states where a person has a tendency to form. They have a thick blood in short. And if you have a rest for more than 3 or 4 days, please, you should be aware that this is a condition which can develop. That is why अगर किसी को fracture भी होता है leg में, there is a plaster. What does the orthopedician say? That move your toes. Why? Because when you move your toes, please do it and see. The pressure comes on the calf, right? So it is like a second heart, you can say. The calf is like the second heart. It is also pumping the blood back, just like the heart is pumping the blood too. So this is flow. So when you move your toes, this is like a pump, right? But some people who are paralyzed, they won't be able to move it. So the family members or the physiotherapist will do this work for them. So again, should be aware of these emergencies. So I'll want to wrap up today's session, but I'll remind you that emergencies, while as unsettling as they may seem, please, they don't have to be paralyzing. Okay?
Sorry, your video has suddenly gone off. Yeah, right.
So emergencies, while unsettling, they don't have to be paralyzing, as I said. By incorporating the insights which we discussed today, you will be better, prepped up to act effectively when needed. So remember that one thing, golden rule: early intervention is paramount. Do not hesitate to seek help, even if it may be, very minor. Do not take anything for chance. Be well informed, proactive. Regularly take a walk through your medical knowledge, be updated, discuss your concerns with your, healthcare providers, your family doctors, or even online you can take, knowledge with all these kind of articles, and such platforms are, very good for awareness. So thank you for today's session. You all have attended it very patiently. And I'm here to answer any questions and offer any support if needed. So take care and stay safe.
Thank you very much. Thank you very much, Dr. Roohi Pirzada, for this session. I think you've been very detailed, and you have touched upon quite a few issues in depth. There are a few questions that have come in, and I'm going to take them right away because I know we have crossed 5:45. So this is from Mr. Rajiv Kumar.
Yeah.
He says, my 86-year-old mother is a cardiac patient with stents and pacemaker. She takes Restil 0.25 mg daily at night to fall asleep. Is continued use of Restil safe? And before I continue with this question, I must just alert everybody here that, while sessions like these and the way we conduct them, we do have very senior doctors in the house, but do remember that specific medical advice is best had by a personal interaction with the doctor, or you take a teleconsult and consult a doctor, because in sessions like these, you can't really give a very focused one-on-one advice. So I'll just repeat this question from Mr. Rajiv Kumar. My 86-year-old mother is a cardiac patient with stents and pacemaker. She takes Restil 0.25 mg daily at night to fall asleep. Is continued use of Restil safe, or should she use another drug to fall asleep?
It depends on how many years she's been taking this and for what reason, whether she had this insomnia or whether it was given for certain panic, disorders. So this will need a little detailed evaluation in clinic with the patient, discussing the history, assessing the reason for being put on Restil. But Restil is like, a very old drug and, quite commonly used, especially in cardiac patients. It's like, it's a part of the recipe, I would say, along with, antihypertensives, your blood thinners, your beta blockers, and one Restil. It's like that. So unless it is having any impact on the liver function test, you don't really need to think of changing it. If it's doing its work without harming the organs, which we are definitely monitoring now and then, I don't see any real pressing need to, shift from that.
Right. Thank you. This is from Shrikant Kulkarni, who's 72. Says, under what circumstances should one take metoprolol?
Metoprolol, it's a beta blocker. Basically, metoprolol is given when a person's heart rate is very high. Like, people who are on an antihypertensive may have a heart rate like 98 or 104, 115. So basically, it is given to control the heart rate. And if a person is a cardiac patient, yes, it is always in the list of drugs given. It is basically a beta blocker to control the high heart rate.
So is it okay, he asks, to take it if the average Systolic is about 55-60.
Yes, if as long as the hemodynamics are not compromised and the heart rate is controlled, we don't have to change it.
Right. This is a question from Shamla Ravi. In the case of
Systolic is 50 or 60, right? I mean, Mr. Srikanth.
yeah, Mr. Shrikant Kulkarni is 55-60. Yes. In fact, he's just asked one more question before I go to Shamla Ravi's. He says, how do you reduce bilirubin content?
What is the reason for the bilirubin being high? Whether there is a chronic liver disease or a cirrhosis or a temporary hepatic infection. No, if the bilirubin is constantly high, then we have to work up with an MRI and a lot of laboratory tests to know why it has been high, whether there is any viral infection, there is any chronic liver disease, or there is a cirrhotic, etiology coming in. And of course, alcohol background or some pancreatic issues or gallbladder issues. So we need to work up for the cause of high bilirubin. And then once we come to know why it is high, then we'll be able to, take steps to do that. Like in liver diseases, we'll go ahead with the MRCP. We'll, assess the liver for elastography and cirrhosis, and then okay, this is the reason. Sometimes it may be a hepatic infection, hepatitis A, which is jaundice. It may be a temporary increase. So it depends on why the bilirubin has come high, and the further workup will tell us how to reduce it.
Right. Thank you. Yeah. So we have this question from Shamla Ravi, which says that in the case of TIA, which is transient asymptomatic attack or hemorrhagic stroke, is it advisable to wait till morning to seek treatment if this happens at night?
If you have understood that it is a transient ischemic attack, and if you had this in the past as well, it is a temporary period of symptoms basically. Like it's like a stroke, but it lasts for just a couple of minutes. Sometimes it may resolve in an hour or so. But yes, it has to be taken up in a hospital setup. You cannot be waiting for it to. If it's a transient ischemic attack, it may be a warning sign of a future stroke. Sometimes very close. Within 24 hours or so, people have developed a full-fledged stroke. So it's always best get to the hospital, get an MRI done, assess, and be safe.
We have a question from Neha Bobre, which I'm going to take that and also generalize it. She asks, what are the precautions one should take for a pre-diabetic, any particular diet and lifestyle? I'm going to just generalize this, broad base it, and say that, as a final takeaway, what are the 3 or 5 things that you would suggest senior citizens should do so that they don't have to, they have a good and easy lifestyle and a healthy lifestyle?
In fact, senior citizens are having a better lifestyle in this current generation who are pre-diabetic at 30. I'm even seeing diabetes at 24 and 26, type 2. So senior citizens, I have seen that discipline in my mother, my grandparents, they really are very motivated. So these 2 or 3 things should be kept in mind, that I will always suggest having a formal dietitian on board. Because we all know, okay, we don't have to eat potatoes, we don't have to eat rice, we don't have to eat sugar, sweets, ghee, maida, mayonnaise. Okay, that's all fine broadly. But if you really want your sugar levels to be, kind of not reversed, I would say, but better day by day, it's always ideal to have a professional dietitians on board who will monitor, or rather, I would say, micromanage your diet. Because we know what to eat, also we know what not to eat. But even the timing at what you eat, sometimes some people eat fruits, like papayas at night. So there are a lot of myths which we all have built up. So it is not what to eat and what not to eat. It is also important that when to eat what. That is very essential. What is the timing? How do you control your sugar spikes? That plus along with 25% of carbohydrates, 50 of protein, and 25 of fiber. So all this has to be balanced, and then you will see a great result in a drop in HbA1c if you follow this particular formal diet. And of course exercises. But if somebody is having arthritis or somebody is not able to walk, what do? There are passive exercises. We get elastic bands for stretching and for muscle strengthening. So even these can be done, sitting at home if you're not able to go for a walk every day. And of course, discipline in timing. You have to be consistent with your timing of food, what you eat, exercise. That should be good enough. And in younger population, if they are pre-diabetics, I would say do your ECG, check your cardiac status, hit the gym, do cardiac exercises, do muscle training, do yoga, meditation, all of this, and of course, avoiding alcohol, high fat and sugar diet. Not only sugar, but high fat diet ultimately is going to get converted to sugars. And not only diabetes, it's leading a lot of people to fatty livers with the deposits of fat in the liver. So fatty liver is there like by default. If the ultrasonography, the sonologist has done an ultrasonography, if there's nothing, there has to be a fatty liver at least. It's in the inbuilt package, you would say. So discipline and food and lifestyle is the mainstay.
Doctor, I need to also ask you one question about teleconsult. Given the fact when we started out, I did mention that the absence of doctors, of the general physician that has happened. How good is it to do a teleconsult and for preliminary issues?
Right. See, acute issues and infections like fever, cough, cold, these are okay. But I still maintain that you have a chronic illness, you have to go to an in-clinic physician because assessment is different physically as well as teleconsults are okay for opinions. Teleconsults are okay for discussing certain reports. You had a lab test every 6 months and you just discuss it out. You have some doubts, queries. That is okay. Acute infections like gastroenteritis or a urinary tract infection or just a COVID fever or a viral fever, it can be handled by teleconsultation. Orthopedic issues definitely cannot be. We all what all maximum we can give is a painkiller or an anti-inflammatory. But if a person is coming with a low backache which is severe, we need to examine him in the clinic. So teleconsultation has a lot of limitations, I would say. And chronic illnesses should not be taken up. And it is not, in fact, allowed by the government of India to start antihypertensive or cholesterol or diabetic medications online. That is a complete red flag here. So I would say, yeah, acute illness is fine.
Great. Thank you very much, Dr. Roohi Pirzada, for this session.
Thank you so much. It's my pleasure.
And for all of you here, remember that this session, the recording will be there on the Seniors Today website by Monday evening. So you can refer to that. We also have a medical practitioner who writes the takeaways of these sessions. So you can also have a look at that and get an understanding of what doctor has said over here. We will be back once again with our next session next Saturday at the same time at 5 p.m. So please be there. You can pre-register for our health webinars. The link is there on the chat window. You can also download our Evergreen Club app, which is also, the link is there. Subscribe to Seniors Today. The new issue of Seniors Today magazine, the January issue, is out on the Seniors Today website. You can refer to that. And we, as we are talking right now, we are beginning to work on the February issue of the Seniors Today magazine. Once again, thank you very much, Dr. Pirzada, for this session.
Thank you.
It's been a pleasure, and we are really thankful to the medical fraternity for taking time out to speak to our senior citizen attendees who are there here in sufficient numbers. On a day like this, because of the long weekend, there may be some lesser number of attendees, but I know they all come back and listen to the and watch the recording on.
Yeah.
Thank you very much. Thank you very much for being here. And we'll see you again next Saturday at 5 p.m. for another session of Health Live at Seniors Today.